Good morning, students. Our lecture today is about a new subject. It is the basic principles of oral surgery. This subject will be divided into 4 parts. In the first part, we will discuss infection control in oral surgery, specifically, and in dental clinic in general. It is an important subject, especially in this pandemic conditions. What is the cross infection or cross contamination? It is the transmission of infectious agents between patients and the staff within the clinic environment. It could be the paths of cross infection. It could be from patient to a dentist, from patient to a dentist, which is the most common. If the dentist don't take the correct measurements of a protection, he will get infected from a patient that have any infectious disease, like in these situations, coronavirus. When the dentist is infected, he will transmit this infection to his family. If the dentist is infected, also he will infect another patient, but this is rare. And if the patient, from patient to patient, how? If you don't clean or don't disinfect the environment after each patient, if you use unsterilized instrument, which is a wrong thing, from patient to patient, this cross-infection may occur. Some terminologies in this subject. What is sepsis and what is asepsis? Sepsis, it is the breakdown of living tissue by the action of microorganisms and usually accompanied by inflammation. So, first we will have a source of infection, an infectious pathogen enter to the body. After it entered to the body, it will go through the bloodstream. At this stage, we call it bacteremia, but it is not sepsis. Not right now, it's sepsis. It's only the blood carrying the bacteria. After that, when the bacteria goes to its target organ, like the heart, the kidney, the liver, the lung, the brain, it will cause destruction of the target organ, and this is called sepsis. It is the breakdown of living tissue by the action of microorganisms, which, if not dealt with it correctly, it will lead to death. So, when we cut the entrance of the infectious pathogen to the body, we will call it a sepsis. The prevention of entering of the pathogen from entering to the body, it's called asepsis. In the medical and surgical field, we have two types of asepsis, which is the medical asepsis, which means a clean technique. What do I mean by medical asepsis? It is the attempt to keep the patient, the healthcare staff, and object as free as possible from agents that causing infection, like wearing gowns, washing hand, wearing gloves, wearing mask, wearing protective gears for the eyes, for the hair, disinfecting articles, disinfecting the instrument, and the uses of antiseptic. This is all called medical asepsis. It's the preparation you do before you receive the patient. Surgical asepsis, or in another word, sterile technique, it is the attempt to prevent the microbes from gaining access to surgically creating wound, When I called it surgical asepsis, it means I have a surgical field. Even the extraction socket, it's called a surgical field because you create a wound for the patient. Extraction, minor oral surgery, even the treatment of a dry socket, it's all called surgical field. So, preventing the microorganisms from entering to this surgical field, it's called surgical asepsis. How could I do this? How could I just achieve surgical asepsis? By using a sterilized instrument. Every instrument I use to do the incision, to do the extraction, to clean the socket, to clean the site of the surgery, it should be sterile, which means free from any pathogens. This is the surgical asepsis, which is an important subject for us surgeons and for us in oral clinic. Another term, we have the term sterilization. What do we mean by sterilization? It is the freedom from any viable forms of microorganisms. It is an absolute state, which means there are no degrees of sterility. I don't say this is half and half sterilization. No, it is either sterile or non sterile. In sterilization, my goal is to kill all the viruses, all the bacteria, and all the spores of the bacteria. The spores of the bacteria are the most resistant part of the bacteria. They are their survival method. They survive through creating spores. So, any method of sterilization, when I measure its effectiveness, I measure it by killing the spores of the bacteria. When this method kills the spore of the bacteria, it's mean I have a good sterilization method. Example is the autoclave, which we use in our clinic. Another terms we have is antiseptic and disinfectant. Both terms refers to a substances that can prevent the multiplication of organisms that cause infection. Both chemical substances that used to prevent the multiplication of infectious pathogens. But the difference is where do I use them? Antiseptic is used on living tissue, like when I use it before surgical operations, or when I use mouthwash for the patient before extraction or before or minor oral surgery. While disinfectant, it is the use of chemicals on innate objects like surfaces, like the dental chair, like the spit-on. This is called disinfection. While antiseptic, it is used on living organisms or of chemical and physical agents that have the ability to reduce or kill the microorganisms on the surfaces on the instruments. Chemical agents examples antiseptics, disinfectants, ethyl oxide gas, which is used for the sterilization of needles, dental needles. Physical agents like heat, irradiation, or mechanical dislodgement, which means the cleaning of the instrument, is also considered a first step in the sterilization of the Now we will classify dental items or dental instrument into three categories based on their uses through the operations or with the patients. We have critical items like surgical instruments or periodontal scalers. These instruments that come in contact with soft tissue and bone, which means instruments that create the wound, like the scalpel or like the periosteal elevator, instrument that will enter into the wound. Even periodontal scalers are entering into the gingival sulcus and may cause wound. So this instrument, they should always be sterilized by heat. These critical items which come in contact with the patient, with the wound of the patient, so they should be sterilized with heat. The other category is semi-critical items, which are items that come in contact with the mucous membrane of the patient, not the wound, like mirrors, handpiece, turbine, like amalgam condenser, like the impression trays, like the digital radiograph sensors. These will have two, these will be divided also into two subcategories. Either heat tolerant instrument, which should be also sterilized by heat, like the mirrors, like the handpiece and turbines, they are all sterilized by heat. Or heat sensitive instrument, which means instrument that will be destroyed by using the heat. So we use either a high level disinfection or disposable barriers, like the radiograph sensor, the digital radiograph sensor. Either I use high level disinfection for it, or I put a sleeve, a disposable barrier, a sleeve on it that will change with every patient. The final category is the non-critical items, which like the radiograph head or cone or blood pressure cuffs. If they are soiled or have any blood on them, any saliva on them, I should be cleaning these items, the non-critical items, only by disinfection. Whenever possible, I use disposable barriers. As I said, the first step in sterilization or disinfection is the instrument cleaning. Either by hand, I clean the instrument, even from saliva. Even if I just examined the patient with a mirror, I should wash the instrument. Either, as I said, either by hand, manually, or ultrasonic through the sonic cleaning devices. This is the first step before any sterilization or disinfection. The next step is the instrument sterilization. We have the most important and most common technique. It is the sterilization with heat. It is either a dry heat, like the oven we use in the clinics, or moist heat. An example of it is the autoclave. In the dry heat, it is the method that the most commonly used in dental offices. They are used to sterilize glasswares, bulky items that withstand heat but susceptible to rust. As we know, autoclaves use a pressure and a steam under a pressure. So if there is any instrument that will will have the ability to rust due to the use of steam, so I use the dry heat. The success of sterilization by dry heat is depend not only on the temperature, but also on maintaining the temperature for a sufficient time. Like, if I use the heat about 170, I must 170 centigrade. I set the oven for 170. When the oven reaches 170, I will measure 1 hour for the instrument to be completely sterile. So it's not only reaching the proper temperature, but also maintaining this temperature for the appropriate amount specified for this temperature. As I said, if it wasn't 70, it should be 1 hour. If it's 160, it should be 2 hours. If it is 150, 2 hours and a half. So, as we see here with the dry heat, we have a problem, that is the time. The time is long for the sterilization. How the dry heat kill the bacteria, kill the viruses? It kill by oxidization of the cell protein. Any protein in the cells, the bacteria cells, the viruses also have a protein. So any oxidization to this cell proteins will kill these microorganisms. So the method of killing for dry heat is by oxidization. As I said, there are some factors that should be followed with the dry heat. The first, the warm-up time for the oven, I should take it in consideration, and the heat conductivity of the material. So I must not overcrowd the instrument for all the instrument to be sterilized equally, and the airflow through the oven. And after the end of the cycle of the sterilization, I must leave it until it cooled down. So we have warming up, the sterilization process, and the cool down. All these will take about 2 to 3 hours, which is a long time in your clinic, which is in your clinic time, which is about 3-4 hours, and you have only 1 set or 2 set of instruments. This sterilization method will be useless for you. So they invented the moist heat or the autoclave to reduce the time of sterilization. The advantage of a dry heat, why I use it? It is relatively easy. The cost is much lower than the autoclave, and don't cause any rust or damage to the instruments like we have in moist heat. But as I said, the most big disadvantage of this method is the time necessary for the sterilization. So we have now the moist heat. It is the most effective, most time efficient method of sterilization that we use in our clinic, in the college, and every dental clinic should have it. The killing or the sterilization method of moist heat is by denaturation of cell protein. while a dry heat use the oxidization, the moist heat will cause denaturation of the proteins in the cells, so thereby killing them. What are the physical principles based on the work of autoclave? When we boil the water to 100 cc, it takes less time to kill the organisms than a dry heat at the same temperature. The water at 100 centigrade will kill the bacteria faster than air, which like dry heat, what we have air, hot air. Hot air at 100 degree, the water will kill it faster than the air. And the other principle that based for the work of the moist heat is that it takes approximately several times as much heat to convert the boiling water to steam, which causes the steam that rises to have more heat, so it will kill faster. When the steam comes in contact with an object, the steam will condense and instantly release the stored heat energy, which will cause denaturation of the cell protein. The use of steam under pressure, what will cause? It will cause the elevation of the boiling point of the water. With this elevation, which means the steam that will generate have much higher heat, which means less killing time. This is the core or the basis for the work of autoclave. Its advantages, its effectiveness, speed, it is available, but the disadvantage is the tendency to dull and rust instruments, such as bears, dental bears, especially the carbide bears. If I use them in the autoclave after one cycle, when I take them out, I will see rust. So, especially carbide bears, I must use the dry heat or the conventional oven, because moist heat will cause rust of these bears. And also the other disadvantage is the cost. It is highly costly, the autoclave, compared to the conventional oven, but it is a cost that worth, because it will save you a lot of time. We have now a little comparison between the dry heat and moist heat. As we said, a dry heat kills by oxidization the cell protein, while moist heat kills by denaturation of cell protein. The time, which is the most critical part, in the dry heat it is long compared to the moist heat, which is short. The equipment complexity and cost, it is low for the dry heat, but it is high complex and costly for the moist heat. Tendency to dull or rust instrument, for the dry heat it is low, while for moist heat it is high. The ability of equipment size for office use, they are both available in office-sized equipment. While for the comparison bit of the temperature, if I see 121 in the dry heat compared to 121 for the moist heat. 121 for the dry heat, it will take about 6 to 12 hours to be completely sterilized, for the instrument to be completely sterilized, while 121 for the moist heat it takes about 24 minutes. Do you see the difference? This 24, this will not include the warm-up time and the cool down. This is the sterilization process, the time for the instrument in this in 121, when the heat reached 121, it will take about 24 minutes for the instrument to completely sterile. So we have a warm-up and a cool down period. So the cycle of 121 will take about 55 to 1 hour, which is also much lower. How do I keep the instrument sterile? I will use sleeves or pouches, either rolls and I cut them with this seal, this device that will cut and seal the pouch, or pre-sealed pouches opened from one side. I will put the instrument inside and will seal it from this side and use them in put them in the autoclave. It will have two indicators that will change when I put them in the autoclave. If you want to check if they are completely sterile, or if you're confused if you enter this instrument to sterilization or not, you only have to check the back of the pouch to see if it's changed color. It means it is completely sterile. When I arrange them, I will arrange them side by side. I will not put them one above the other. Why? Especially the surgical instrument have sharp points. If I stack the pouches one above the other, I may have puncture of the pouch and I will lose all the sterilization. So I will arrange them side by side. Another technique of aseptic environment is the technique of instrument disinfection. Many dental instruments cannot withstand the temperature required for heat sterilization. Therefore, if I could not use sterilization, then chemical disinfectant should be used for the disinfection. Chemical agents with the potential disinfectant capabilities have been classified into low, intermediate, and high level of biocidal activity. How I measure them? Low biocidal activity, which means chemical disinfectant that will kill only vegetative bacteria and lipid viruses, but have no effect on non-lipid virus or the tubercle bacilli, which is a resistant a resistant type of bacteria, or the bacterial spores. This is the low. The intermediate type of disinfectant will kill all them, will affect all the mentioned microorganisms except the bacterial spores, while the high level disinfectant will kill them all. This is important classification to know. Agents with low biocidal activity are effective, as I said, only for a small range of pathogens compared to the intermediate and compared to the high. The capability of these disinfectants not only on their innate properties, it will not based on the innate properties, but also most importantly on how chemicals are used. It is important thing for disinfection to use them properly so that you have a complete disinfection. What are the substances that we used or acceptable for dental instrument disinfections? It's glutaraldehyde, which is the most commonly used, iodophores, chlorine compounds, which is the hypochlorite أو القاصر, and formaldehyde. Alcohols are not suitable for general dental disinfection. Why? Because they evaporate rapidly. But we can use them in disinfection of local anesthesia cartridges if they need disinfection. The procedure, the exact procedure for the disinfection will be as follows. The agent or the disinfected agent should be formulated and diluted according to the manufacturer. The instruction of the manufacturer should be followed completely. After I clean and wash the instrument and I put the solution, the disinfected solution, in the tray, I will submerge all the instrument. They should be completely submerged under the solution. After this, I will calculate the time according to the manufacturer, like مثلا say 5 millimeter and 10 milliliter, 5 milliliter and 10 milliliter water. You should leave the instrument for half an hour, and like so. So they must be in contact with the solution for all the designated period. I should not take them before the designated period. After this disinfection, I rinse them because they are all in chemicals. I cannot use them immediately, and they should be used within short time. This is for emergency disinfection or for instrument that cannot withstand heat, not for the normal surgical instrument that withstand heat. Another thing for achieving aseptic technique or aseptic environment is the surface disinfection. This is an important line of disinfection. What I should disinfect in my clinic? I should disinfect all the chair, the tray, the handle and the light, the counter that I use, even the doorknob. All these are important sites that I should do for them surface disinfection. Another is the spit-on. It is one of the most important sites that you students all forget to do disinfection. And the headrest. The most important part of the chair is the headrest. What about me, the surgeon or the dentist? What are the protective measures that I should use to prevent cross-contamination? First, the protective covering, like uniforms, the lab coat or the surgical gowns, the gloves, the mask, face shield, protective glasses, all these are important personal protective measures that I should use, especially in these pandemic conditions. Another is the surface barriers for the chair, especially the hairdressed, for the handle of the light. These are the two most important things that I should use surface barrier for. Another is the turbine and the handpiece. Also, I have sleeve on them. Also, what we have, the tray, as we see here and we see here, should be also covered in surface barriers. Another protective measure is the handling of sharp instrument and needles. This is the wrong way to close the needle. Any slippage, any movement, you will cause self-injury and may cause a cross-contamination from the patient. Any used needles should be closed by putting the cover on the tray and then inserting the needle in it. This is the correct way for handling sharp objects. The disposal of sharp objects, I should dispose them in a specified containers, or if I don't have a specified containers, I use any hard plastic containers like detergents, empty detergent bottles, and use them as a sharp container disposal. After it will filled, I will close them and dispose them with the medical waste. If I accidentally have an injury through a needle, through a probe, what should I do? The first thing I do, I should go and wash the injury site under running water. After that, I will use alcohol or any antiseptic to clean the wound and disinfect the wound. After that, I will inform my supervisor and then ask the patient for a blood sample and send it to a laboratory so that I be in a complete clearance. But the important thing, better be safe than sorry. Be use the correct method for handling the sharp instrument and prevent injury. This is the best way to be safe. The second part, the subject of basic principles of oral surgery, is the management of hemorrhage. It is an important subject, could occur to any dentist during normal extraction or any minor oral surgery. So every dentist should know how to deal with any case of hemorrhage and bleeding. After. What is hemorrhage? Hemorrhage is a prolonged or uncontrolled bleeding. It is a common complication in oral surgery. As I said, it could occur after a normal extraction of the tooth or after any minor oral surgery like impaction or episectomy. This bleeding occur due to trauma to the vessels in the region, as well as problems related to blood coagulation, like patient with hemophilia or patient taking anticoagulant drugs could suffer from hemorrhage. Postoperatively bleeding in healthy patient may be the result of poor hemostasis of the wound due to insufficient compression or inadequate removal of inflammatory or hyperplastic tissue from the surgical field. So it is very important to achieve hemostasis in all patients during any oral surgical procedure. What is the hemostasis? So, what is the hemostasis? Hemostasis, it is the process that stops blood loss from damaged vessels. It is a normal mechanism in the body. Any wound in the body, this hemostasis process will start to stop the bleeding from the wound. It consists of several phases. Phase 1, or the vascular phase. In this phase, will be activated by the signals from pain receptors in the sites and smooth muscle injury and serotonin release from the platelets will cause vasoconstrictions of the blood vessels in the area of the injury. So the first phase of the hemostasis is vasoconstriction of blood vessels in the area. After that, the second phase will start, which is the platelet phase. This phase will be triggered by the exposed collagen from the wound, will lead to platelet adhesion to the injury site. These platelets will release factors that cause more platelet aggregation to the area and causing platelet plug formation. At this stage, we will have primary hemostasis. This platelet plug will stop the bleeding until the coagulation starts, and until the coagulation phase start. After the end of the phase 2, platelet phase, which is ended by the formation of platelet plug, this platelet plug will release factors that will start the third phase, which is the coagulation phase. In this phase, we will have both intrinsic and extrinsic pathway. In both phases, we will have the activation of prothrombinase enzyme. With the presence of calcium, it will convert the prothrombin, which is normally found in the blood, a soluble protein normally found in the blood, to a thrombin. And then this thrombin, along also with the calcium, will cause the fibrinogen to become fibrin. The soluble fibrinogen, which is normally found in the blood, to become a fibrin, which are which are collagen mesh. The fibrin is like collagen mesh that will bridge the gap of the wound, close the wound, along with RBCs, platelets, and cause the clot formation, a stable clot formation. These are the three important phases of the hemostasis. Phase 1, we will have vasoconstriction. Phase 2, we will end with the platelet aggregation and the platelet plug, which is the primary hemostasis. At phase 3, the coagulation phase will end with the clot formation, the non-clot formation, and this is called also the secondary hemostasis. In oral surgery, this hemostasis will be translated into a timeline. At time 0, we will do the extraction or the minor oral surgery. In seconds after the extraction, the vascular spasm will occur, followed by the platelet plug formation. In minutes, we will have the primary hemostasis. This will take about 30 minutes. That is why with the primary hemostasis, which is the platelet plug formation, will occur in about 30 minutes. That is why we tell the patient you keep biting on the cotton for 30 minutes, so that after 30 minutes we are sure that the platelet plug has formed and there is no more bleeding. After that, the clotting or coagulation process will start, starting with the cycle, intrinsic and extrinsic pathway, ending with the fibrin clot, and after 24 hours we will have a stable fibrin clot and the transformation of this fibrin clot into a granulation tissue. By 24 hours it should be we have no bleeding. The complete hemostasis stages. What are the types of hemorrhage? According to the duration of hemorrhage or the onset of hemorrhage, it is classified into three categories: primary bleeding or primary hemorrhage, which occur at the time of the injury, which is normal due to the trauma to the blood vessels, due to extraction, due to the flap incision and the flap formation. This is normal, which occurs at the time of injury. And the hemostatic mechanism in the body will attempt to stop the bleeding by the formation of the clot. With the start of the primary bleeding, the hemostasis stages will start. The intermediate bleeding or reactionary bleeding, it occurs within 8 to 24 hours after the surgery. It could occur due to loose foreign body in the wound, like calculus or a broken bone or pre-existing granulation tissue in the extraction socket. These are the most common causes of the bleeding during the first day of the surgery. The secondary bleeding, which occurs after 24 hours from the surgery. It could occur due to dislodgement of the clot, secondary trauma to the wound, like any bite, unnecessary biting to the wound, or the patient to play with his tongue with the socket. Any infection, which is the most common reason for secondary bleeding, or if the patient hypertensive, any elevation in the patient blood pressure will cause pressure on the blood vessels and the start of the bleeding again. So we know the hemostasis, what is the hemorrhage, what is the normal mechanism of hemostasis, what are the types of hemorrhage. Now should know, every dentist should know, what should I do when I have bleeding, when I have hemorrhage. The local measures to aid hemostasis following minor oral surgery. First of all, which we all do after any extraction, it is the digital pressure. When we finish the extraction of the tooth, what we do squeeze of the socket. This digital pressure and squeeze of the socket, the aim of it is not only to return the bone to its normal contour after the expansion due to the extraction movements, but also to aid in the hemostasis. We aid in the vasoconstriction of the blood vessels. And after that, we put a cotton to the on the wound on the extraction side, and we tell the patient to keep biting on it. This biting will provide also pressure, and as I said, we tell the patient to keep biting on this cotton for 30 minutes. This time is important. I don't tell him for 1 hour. I don't tell him for 2 hours. 30 minutes is more than enough to achieve the primary hemostasis. So the first aid, which we all do, and the easiest, is digital pressure. The second is the use of hemostatic agents. Like, first of all, we have tranexamic acid. It may come as an ampoule or as a mouthwash. It can be effective in controlling postoperative bleeding. What is the mechanism of action of tranexamic acid? It acts by binding to the plasminogen, which is found in the blood, and inhibiting the subsequent fibrinolysis. After the formation of the fibrin clot, if there is any problem or any premature lysis of this fibrin clot, will lead to return of the bleeding. So this tranexamic acid will cause inhibiting of any fibrinolysis, which means keeping the fibrin clot more time. How will I use it? Either by making the patient rinse his mouth with it as a mouthwash, or I use a syringe and squeeze the solution on the socket, or I dampen a cotton roll or a cotton with the tranexamic acid and make the patient bite on it. Another agent, we have ferric sulfate. It is mostly used to arrest gingival bleeding. The mechanism of action for ferric sulfate is by sealing the damaged tissue mechanically, like making a mesh and sealing the damaged blood vessels or the damaged tissue mechanically. It is associated, but the problem with ferric sulfate is the adverse reaction, which is inflammation and delayed osseous healing. So we have to be careful when using this agent. Another hemostatic agent is silver nitrate. It is like a matchstick, which causes cauterization of the wound and thereby sealing any source of hemorrhage, and accelerate, by this we will accelerate the clotting process. Another agent, which is also, this agent is available, should be available in every clinic, which is the adrenaline. It should be in your emergency kit for any patient having anaphylactic shock, and simply it is found in our normal local anesthesia. What is the primary mechanism of action of adrenaline? It will cause vasoconstriction. This is the primary mechanism of adrenaline. So either by dampening a cotton roll or gauze with the adrenaline, or with lidocaine, which is which will have adrenaline in it, and make the patient bite on it, or I could simply squeeze the solution of adrenaline or anesthesia on the wound and wait for the vasoconstriction to occur. Another agent that control the hemorrhage in oral surgery is Surgicial. What is Surgicial? It is a topical resorbable hemostatic agent consisting of oxidized cellulose. It is like a mesh of oxidized cellulose that I put inside the socket. The main mechanism of action for Surgicial is the formation of matrix that will help in the aggregation of a platelet and accelerate the formation of a platelet plug. It is often placed, as I said, in the extraction socket to aid in hemostasis. I could use suture to secure it in a place, or I could leave it without a suture. It will help. This Surgicial will remain in the socket for about a week until its resorption. As I said, it is resorbable, so there is no need for another visit to remove it. Another method for controlling hemostasis and really available in every dental clinic is sutures. Sutures are useful in control bleeding if it is due to soft tissue hemorrhage, which means hemorrhage from the gingiva. It will act mechanically by obstructing the blood vessels and thereby cause the stoppage of bleeding. We could use either figure of 8 suture or horizontal matrix suture to control the bleeding. The suture for controlling the bleeding should be left about 2 to 3 days to ensure there will be no any secondary. Another method is the use of gelatine sponges. These are hemostatic resorbable gelatine sponges. They are cubes of sponges. They're effective in controlling the post-extraction bleeding as well as minimizing the other complications like infections or dry socket. These are used like Surgicial by placing them in the wound, in the socket. We could put them either without suture or we could use figure of 8 suture to stabilize them. These are also resorbable, so there is no need for another visit. Another method is bone wax. The mean of bone wax, it is a wax that is used to stop the bleeding from the bone. That is the meaning of bone wax. It is an unresorbable mixture of beeswax, paraffin, isopropyl palmate, and a wax softening agents. These bone wax aids in the hemostasis. What is the mechanism? By occluding bleeding channels in the bone. It will close the bleeding channels in the wound. I will soften the bone wax with my hand. I will knead them until I form a soft dough and then put them on the bone to occlude any bleeding channels. The bleeding from the bone is so much distinguishable from bleeding of soft tissue. How do I distinguish it? I reflect the soft tissue carefully. Then by using a cotton, I dry the area of the bone and then I will see if there is any bleeding from the bone. I will see the points of bleeding. After that, I will use the bone wax to put it on the bone and close these bleeding channels. But the problem with bone wax it is not resorbable. So it cause many adverse reactions like impairing of bone healing, the causing of, if it is left, will cause granuloma in the area or even infection. So if I use bone wax, it will need a second visit, a second surgery to remove the bone wax. The final method for controlling bleeding is ligation and electrocautery. Ligation, it is the most successful way to control soft tissue hemorrhage that involves large blood vessels. In ligation, what will I do? I will ligate, I will tie a large blood vessels. If I have, for example, this is a palatal incision, this is the greater palatine artery. This is a common complication when doing a palatal incision. It is the severance of greater palatine artery. So I should do ligation for this large vessel. I will clamp the artery, the severed artery, with artery forceps, and then I will tie a suture around it. This is the ligation process. If I have a large blood vessels, I use ligation, sometimes only if it is a smaller blood vessels, only the clamping of the blood vessels will cause the stoppage of the bleeding. While electrocautery, it is based on the coagulation of blood through the application of heat, which result in retraction of tissue in a necrotic mass. I will cause necrosis at the site of the severed blood vessels and thereby cutting the bleeding, stopping the bleeding. Ligation is often used to arrest hemorrhage from large blood vessels, while in electrosurgery or electrocautery, I use it to stop the bleeding from small blood vessels. Another difference is that in electrocautery, it will seal the damaged vessels by heat, while in ligation, it involves tying off blood vessels with sutures. These are the 8 methods that we could use in hemostasis. Some are available in our clinic. If the bleeding is non-stop or out of the scope of your expertise, you should always refer the patient immediately to an emergency room, because bleeding a large volume of blood will result in fainting, and if not treated, it will result in extreme loss of blood and then death. So if you could not handle the bleeding, or you don't have the proper measures to aid in the control of the bleeding, you should immediately take the patient to an emergency room. The last subject we have is the hematoma formation. What is hematoma? It is the collection of blood outside of blood vessels but inside the tissue. Bleeding, it is the expression of blood out from the blood vessels out of the tissue. While hematoma, it is the collection of blood due to injury to the blood vessels inside the tissue. This is the appearance of hematoma. Hematoma could be as a result of either venous or arterial laceration. It is more commonly associated with local anesthesia injection, especially with the inferior alveolar block. Why? Because when I give injection to inferior alveolar block, what travels with the nerve is the blood vessels. So if I come near to the blood vessel or I enter the blood vessel, I will injure it, and then after I retract my needle, I will cause a bleeding inside the tissue and then the formation of hematoma. The size of hematoma depends on the density and the compactness of the tissue. If I have loose connective tissue, I will have a large volume and a severe swelling of hematoma. But if I have a compact tissue like muscles, I will have a smaller, more controlled hematoma. What is the main symptom that I see? It is the discoloration, the bluish color or the bruise that will indicate this area have a hematoma. It could also be occur not only in a block, in a inferior alveolar block, but also if I give infiltration and I hit a small vessel, I see a bluish color in the area. This is mean a small hematoma. If I have this complication, what should I do? What are the management of hematoma? After the hematoma, the first sign of hematoma will be swelling and then the changing color. So if I see the swelling immediately after injection, I should apply a pressure, localize the pressure on the area. I will do squeeze in the area to aid in stopping the bleeding, to aid in vasoconstriction. and wait for about 2 minutes, minimum 2 minutes. I will keep pressure from 2 to 5 minutes. It's preferable to keep the pressure from 2 to 5 minutes. After that, the hemorrhage should be stopped, but the hematoma will be formed. So what will I do? I will tell the patient that this is a normal complication. The swelling and the bruising and the discoloration will disappear after 10 to 15 minutes. I will inform the patient to do ice packs for the first 24 hours from the surgery, and in the next day, I inform him to do intermittent hot moist packs with massage. He will use a towel soaked in hot water, then squeeze it, then put it on his cheek from the outside, or I told him to rinse with warm water and then do massage to the area to aid in the breakage of this collected blood. If I suspect this hematoma may develop any infection, I could prescribe antibiotic to the patient. At this point, we finished the two parts of basic principles in oral surgery. We discussed infection control and hemorrhage control in oral surgery. See you in the next two parts. Thank you.